Hello, my name is Charles Small. I will be the attending physician for week 4. This week we have the case of a 48-year-old man who presented in November 2009 with decreased visual acuity, painful ocular movements and photophobia, and inferotemporal visual distortion. This was associated with mild ataxia and a 9-day history of severe dull frontal headache, not worsened by the Valsalva maneuver. He has no past ocular history, and his medical history consisted of sciatica and psoriasis. Ocular examination revealed decreased visual acuity of 624 on the right eye and 6.6 on the left eye. Dilated fundus examination revealed an isolated finding of bilateral optic disc swelling on the right side more than the left side, with associated splinter hemorrhages on the right. There was no evidence of restriction in ocular motility, such as the sixth nerve palsy, which is a known false localizing sign for raised intracranial pressure, nor was there any other cranial nerve palsy identified. Reliable Humphrey visual field test showed bilateral diffuse field loss. Following admission under the medical team for presumed raised intracranial pressure, beta blockers were commenced to relieve the headache, and radiological and hematological tests were performed. Chest X-ray and computed tomography were conclusive. Magnetic resonance imaging of the head and orbit showed non-specific changes that did not appear to be of clinical significance. Ventricles, basal cisterns, and sulci were normal and symmetrical. Initial blood tests, including autoantibodies and syphilis serology, were also negative. On review 2 days later, his visual acuity was further decreased to 624 in the right eye and 636 in the left eye. Ishihara's testing revealed a significant decrease in color vision, and 4 out of 14 in the right eye and 3 out of 14 in the left eye. Intravenous high-dose methylprednisolone was initiated 1 gram daily for 3 days, followed by oral prednisolone 40 milligrams daily, tapered by 5 milligrams weekly. A lumbar puncture was performed, which revealed a normal opening pressure, helping to exclude papilledema in the presence of findings of bilateral optic nerve swelling. Further analysis of the cerebrospinal fluid found white blood cells and glucose levels to be within normal limits, and there was no evidence of microorganisms on microscopy. Red blood cell count was slightly elevated, but in the absence of intracranial hemorrhage on cranial imaging, it is likely that this was secondary to the traumatic tap. Further blood results revealed a positive test result for B, Bergdorf-Ferry by Lyme enzyme-linked immunosorbent assay and Western blot serology. The patient had no recollection of any recent tick bites, but had sustained bites previously. Therefore, the diagnosis of Lyme disease was made in the absence of erythema migrans, because there was a history of exposure to an endemic area, involvement of at least one organ system, and a positive result from the laboratory. The prognosis is Lyme disease.